Thank you very much. No financial interest. And when we think of conditions that present with sudden visual loss, there are certain conditions that could be either sight-threatening or, more importantly, they could be sometimes life-threatening also. And time is of utmost importance in diagnosing them because certain diseases are those that demand a multidisciplinary approach. From a retinal perspective, considering the time span and the frame that we have, I thought I'll concentrate on these 5 conditions which would present to a general practice. Maybe one case per month or one every other month, you would be able to see one each of these kind of cases. So you'll be able to understand what exactly we should be doing for these cases. Of course, all these cases require a referral to a vitreoretinal surgeon as early as possible, but if you can make a diagnosis, that would improve your own clinical situation and acumen. First is the vitreous hemorrhage. We all know that's a very common thing that we would see. And the commonest cause is, of course, PDR. And we have a extensive talk on PDR and diabetic retinopathy. So I will not be going into details of PDR. But what I would say is acute PVD with a break. That is an important thing that we should not miss, because the rest of the conditions, mostly vascular retinopathies, do give us some time to act on. But if there is a break, around 70% of patients with a vitreous hemorrhage and PVD or posterior vitreous detachment can have a horseshoe tear. And if that is not diagnosed, many of them, around 50%, 40 to 50% can progress into a retinal detachment. And if the detachment occurs in such a way with the macula on, that is something like a real emergency. Because of sustaining the vision for that patient is important. If you do the surgery earlier, the vision is retained. Otherwise, when the macula is off, the chance of regaining the pre-op vision, regaining the vision prior to the detachment is rare. So you need to give an urgent referral, and you need to do a scleral depression if you can. And I'm sure that everybody will be interested in doing it. You should start doing it if you are not doing it. And sometimes you can get a confusion between a break and a hemorrhage. You can look at the break as a clear edges with a flap, and it opens up when you do a scleral depression. And always look for the break, because as the father of retinal surgery says, Jules Gonin remarked that seek the holes, search for more holes, and seal the hole. So that is what we need to do. At times you can have more than one break. Like here you can see the multiple horseshoe tears. And we'll see what a close-up of a horseshoe tear really looks like. And the PVD occurs from posterior to anterior. And wherever there is a strong vitreous attachment, it tears that retina. As you can see, the horseshoe tear. And the horseshoe takes the shape in such a way that it faces towards the disc. The horse walks towards the disc. So that's the way the shape of the horseshoe is. And you can see here that there are bridging vessels here. And these are the ones which get avulse and bleed. And this you can see the edge of the lattice. So that's where the strong vitreous attachment is. And the bridging vessels are the ones which bleeds off. There's one more I would like to show you. And here you can see clearly the vessel which would have been ruptured when the tear occurred, and the bleeding occurs at that time. And when you see those breaks, you're supposed to refer to a retinal surgeon who would do a barrage photocoagulation. And if the media precludes the laser, we can also do a cryopexy to ensure chorioretinal adhesion. In those cases, the risk of retinal detachment is actually reduced from about 40 to 50% to about 3%. And right from our undergraduate days, we've been taught that central retinal artery occlusion is a medical emergency. It's an ocular emergency as such. But the ironic fact is that as ophthalmologists, we do nothing except diagnose and send it to the patient. But that is a very important thing that we are doing. And if the patient comes within that golden hour of 100 minutes, then you can probably try ocular massage. Evidence is divided whether it works or not, but I've heard anecdotal reports from my seniors that it does work. And indeed, in my own experience, I would like to share that I have had a patient who came with a poor vision. Within 30 minutes of drop in vision, and I did an ocular massage with the mainstay standard. And I saw the emboli in the trunk. And on massage, it's just dislodged off from the trunk into the inferior arteriole, and then suddenly got pulverized and disappeared. And the patient miraculously, from counting fingers 1 meter, went to 680. But that is only one case in the last 25 years. But it does work. So there's no harm in just giving it a try. And if you suspect arthritic, that is, if you see a pallid disc edema, think of workup on GCA also, giant cell arthritis. They can also present with a transient monocular vision loss. CRA patients can also present with a good vision if there is a macular sparing because of the presence of a cilioretinal artery. And the American Stroke Society, this association has considered it as a acute ischemic stroke of the eye. And so therefore, if you see the cherry red spot as you see here, corresponding hyperreflective area in the inner retina, it's imperative that you have to send the patient for a detailed workup with a cardiologist or a neurologist for a stroke evaluation. I will not talk much on central retinal vein occlusion. We all know about the disease and also understand what is blood and thunder appearance. Suffice it to say that early visual loss is mostly because of CME and also ischemia. And the later visual loss comes in because of the sequelae to neovascularization. Another common thing that we would encounter is a macular hemorrhage of various causes, especially neovascular AMD, PCVs, myopic chorioretinal neovascular membranes, and valsalva retinopathy. Myopic CNVMs respond well to any anti-VEGF treatment, but they also need to be treated well and also looked at the periphery for changes of myopic peripheral degeneration. Sometimes large bleeds, like the one you see here, they look, it's treatable, but these are the eyes that do bad. Sometimes these kind of hemorrhages can take the eye from a reasonably good vision to no PL, even with adequate management, because of the extensive areas of lesions that could bleed during treatment and further. So you have to be very careful about the prognosis that you would be giving to that patient. And a retinal macroaneurysm, as in here, you will see a multiple layer hemorrhage, subretinal, preretinal, and all those kind of things. So sometimes this blood, usually it's resolved by itself, you don't need to do anything. But at times, in 5 to 10%, they can develop a macular hole, as in this case, and then would need surgery to resolve the condition. And all of you know about valsalva retinopathy. It's nothing, it's one of the diseases what we are talking about would give a better outcome. So I thought I'll end my talk in a positive way. So this is a patient who came after a strong workout. He was a gym enthusiast and he lifted the weights and then suddenly he found his left eye was not seeing well. So he came and saw me. I gave him the option that we could do a laser hyaloidotomy and probably that will resolve in some time. And luckily it worked and he was kind enough to stay put in the hospital till I could take multiple serial photographs. And then when I overlaid all the photographs, I got this dramatic response that you would see. And this is the way the blood comes off immediately. Within, in the sense, immediate I meant, about 3-4 hours time, slowly the blood started coming down and it cleared up. And so, to conclude, I would say most of these conditions are serious conditions and need to be taken care of as early as possible. As I said, time equals vision in this condition. Certain times, time equals to other problems for the patient because you need a carotid Doppler to look for decreased blood supply to the brain and all those kind of things. You need a multidisciplinary condition. So it is wise to understand this disease as well, and so that we don't miss any of these red flags. Thank you very much. Thank you, Dr. Vidya.
Thank you, sir. Sir, one doubt.
I was running away, actually. Yeah. Tell me.
So often in OPDs, we deal with this transient monocular vision loss, like gone in a flash, got back in a flash, like that. And some of these patients will be females who's giving history of migraine. Now that it is our job to extract the knowledge from them, like is it real emergency or it is something related to migraine or something. So what is your take on that, sir?
Even ocular migraine, my understanding now is that it is supposed to be considered as a transient visual loss again, and we need to have an evaluation on that side too. It's not currently. I think it's considered as would be imminent kind of a vascular occlusion or something like that. But opinion I think is divided. But certain neurologists do consider it as a forerunner to something more serious than just an ocular migraine. So you need to evaluate with the neurologist also in that condition. That's my opinion on this.
So any case of transient monocular and neurology opinion is...
Any TIA now is considered as a sort of a employment towards a stroke. That's coming. Right. Thank you.
Thank you, sir.
Thank you so much, sir.